And this is an interesting case of endometriosis with Pyosalpinx with peritonitis. She is a diagnosed case of endometriosis 1 year back, and she came to me at that time. She was not willing for laparoscopy at that time. Now she was diagnosed with Pyosalpinx and she was having deep severe dyspareunia. Actually, this is her second marriage. She got divorced because of dyspareunia. So now what you can see is that after entry, this is actually the palmar entry. After entry, we are seeing only the bowel loops and the stomach completely adherent to each other and also adherent to the anteabdominal wall. We have entered the cavity with just the 5 scope, and we are we are inspecting the abdominal cavity. What you are seeing right now is the stomach, which is adherent to the anteabdominal wall. Now we are searching for one other space so that we can put a secondary trocar to visualize the cavity, so that we can change the scope to that trocar and we can see the point of entry of the primary trocar, so that if any injury has happened, we are now searching for this space. What you are seeing is the stomach, which is actually adherent to the anteabdominal wall. We are searching for a space. So now you can see the bowel loops which are matter to each other. Now what you are seeing is the anteabdominal wall, which is free of bowel adhesions. So we are planning to put the secondary trocar in this area. So this is the secondary trocar, which is coming from the lateral abdominal wall. Now we are changing the scope to the newly put trocar to visualize the primary trocar. We are inside now. So this is the primary trocar. This is the palmar space. This is the primary trocar. We have not made any injury. It's a narrow escape. We are safe as of now. Now we have changed to the primary trocar. Now we have started dissecting with only one secondary trocar. Now what you are seeing is the sigmoid, which is adherent to the anteabdominal wall. This is all small intestine. So we are just started releasing the intestinal loops so that we can see the pelvis. Now we are planning to put the suprapubic trocar after adhesiolysis. So some of the bubble loops which are adherent to the anteabdominal wall were released. This is the secondary trocar. Now what you are seeing is the anterior surface of the uterus and the sigmoid loops which are actually adherent to the lateral pelvic wall. So we are planning to release the sigmoid loops and also the right side there. This is actually a pelvic inclusion cyst on the right side. So the both sigmoid and the rectum is completely adherent to the uterus and the pelvic inclusion cyst. The structure which you can see behind that flimsy adhesions is the huge right side Pyosalpinx. It's a very huge Pyosalpinx on both sides. What you can see is the Pyosalpinx full of pus inside. Now we have started dissecting the adhesions over the anterior surface of the uterus. What you can see is that the sigmoid, which is densely plastered to the anterior surface of the uterus, and now we are slowly releasing it. This is the sigmoid adhesion. Now you can see the round ligament, left side round ligament, and the mass which you are seeing right now is the left side Pyosalpinx, huge Pyosalpinx. These adhesions will cause a lot of neovascularization, so there will be a lot of newly formed blood vessels. This is actually the sigmoid, which is adherent over the left lateral abdominal wall, which is getting released. We have to adequately dissect the sigmoid and push it down so that the lateral wall dissection will become very easy. Now we are opening the space behind the hydrosalpinx, and what you can see is the space between the rectum and the left side Pyosalpinx. We are dissecting the space between that. So left side, what you can see is the huge Pyosalpinx, and the right side is the mesorectum, which is being dissected. We are using the harmonic to release the adhesions. What you are seeing is the mesorectum, which is completely plastered to the Pyosalpinx. We are lateralizing the mesorectum. We are medializing the mesorectum completely from the Hydrosalpinx. This is actually the adhesion between the lateral pelvic wall and the Pyosalpinx. We are dissecting the space between the lateral pelvic wall and the Pyosalpinx, the posterior surface of the Pyosalpinx. Now we have opened the lateral pelvic wall, and you can see the other side of the Pyosalpinx. We are dissecting into the lateral pelvic wall. Above you can see the round ligament. The lateral pelvic wall attachments are completely released from the Pyosalpinx. It's a huge Pyosalpinx. So releasing the adhesions from the round ligament. So now releasing the posterior compartmental adhesions between the mesorectum and the Pyosalpinx. It is densely adherent. This is the pelvic wall. Now you can see the pus coming out of the tube. Slowly we are releasing the Pyosalpinx from the peritoneal attachments. What you can see on the right side is actually the mesorectum. Laparoscopy is all about traction and counter traction in the correct plane. So now proceeding with left side total salpingectomy. The adhesiolysis in and around the Pyosalpinx have been done. Now proceeding with the salpingectomy. This is the lateral pelvic wall adhesion which is being released. This adhesiolysis will make the ureter further away from the plane. these are the adhesions with the rectum. It has been released. Here on the left side, even the endometriotic cyst has got infected, and the cyst was full of pus. So we have proceeded with the oophorectomy on the left side, but on the right side we have preserved the ovary, and surprisingly her AMH was good, and she is for infertility. We have preserved her right ovary. We wanted to preserve the left ovary also, but since because it has got infected and the endometriotic cyst has fully converted into pus, we have to take the ovary on the left side. We have started dissecting on the right side. So what you are seeing is the pararectal space basically. The dissection is between the right side mesorectum and the right side adnexa. So what you are seeing is the infundibulopelvic right now, right infundibulopelvic, and the rectum is medialized, and the mass which you are seeing is the right side Pyosalpinx, which is densely adherent to the mesorectum. Now we are separating the plane between the mesorectum and the Pyosalpinx. The Pyosalpinx is also densely adherent to the posterior pelvic wall. It is very densely adherent. And also you can note the Pyosalpinx adherent to the uterine wall. We have to be sure of the ureter on the right side. So you can see the adhesions between the posterior pelvic peritoneum and the Pyosalpinx. So we are now trying to get a plane between the ovary and the peritoneum. As of now, we have only two secondary trocars, one on the left side and one on the suprapubic. No right side trocar has been placed because of the ileal loops adherent over the abdominal wall. Slowly the adhesion is getting released. We are searching for the ureter. We have actually dissected the ureter at the level of the pelvic brim, and the ureter is under our vision. Sometimes these cysts or this Pyosalpinx can be densely adherent to the great vessels of the lateral pelvic wall. We have to be very cautious. You can see the round ligament on the right side, which is very taut and inflamed. This is the carnua, right carnua, and we are going to bisect the tube from the carnual attachment. Slowly dissecting it from the uterine adhesions. You can see the pus coming out of the tube. This patient was having very severe pain for the past 6 months, and we should do justice for her pain, and the main purpose of the surgery to improve the quality of her life. It's a hard indurated mass. It's all hard. It has become fibrosed. Its long-standing Pyosalpinx and endometriotic adhesions can become fibrosed. And she was on Dynogest for a long time, which can also be one of the reasons for dense pelvic adhesions and fibrosis. You can see the pus coming out. Now both the sides salpingectomy has been done. Because of the new vascularization, there will be minimal bleeding. can appreciate the anatomy. So bilateral adnexal adhesions has been released. Bilateral tubectomy has been done. Now only the remaining adhesion is the rectum adherent to the posterior surface of the uterus, which is also been released, and the normal anatomy is completely restored. The only good part is that she was not having any adenomyosis. This surgery was done a couple of days back and she is recovering well. Hope she won't be having dyspareunia hereafter and she will be having a better quality of life. Thank you. Thanks a lot for watching my surgery. Thank you for your support.